Today, it's all about healthcare. And really, it's healthcare from the Economist point of view.
The U.S. Congress invested roughly $5 billion in 2020 to increase fee-for-service or traditional Medicare services. They did not make that same investment on the Medicare Advantage side.
If you call 911, Medicare Advantage plans theoretically can charge you whatever out-of-pocket they want to, and they're doing that.
The hospitals have done a tremendous amount of fear-mongering around the new changes to Medicaid in the bill. As an economist, I cannot come up with the math equation that goes along with that rhetoric.
Well, welcome to another episode of the Leadership Lab with Asbel Montes. Excited that you've joined us as well, and I'm really excited to be in studio with someone that I have known for many years and who is now, I have to call her a doctor, but we'll introduce her here in just a minute. But today it's all about healthcare, and really it's healthcare from the Economist point of view. And so I'm here in the lovely city of Milwaukee, Wisconsin. And I actually got to have some cheese curds last night, so I was really excited about that. But Lisa, thank you for joining me here on the Leadership Lab. And I'm going to call you Dr. Grabert because you've worked very hard for that. And so I want you to take us on a little bit of a journey of your history. Many people that may be watching this may not know who you are. Some of us have known. And usually what I talk about is I don't like to get into groupthink and always assume that everybody knows what I know. And I'm excited about having this conversation because there's so much happening in the healthcare arena right now. And so give us a little bit of your background, what brought you here today, and then we're going to kind of talk a little bit more from the healthcare economist position, but I'll get into that. But I want to talk a little bit about who Lisa is.
Sure.
Or Dr. Grabert.
Just a new Dr. Grabert, too. I'm on the faculty at Marquette University, which is a Jesuit college here in Milwaukee, Wisconsin. And I'm in the College of Nursing at Marquette, and I teach a health policy class to graduate students. And I've been in academia for 7 years now. Prior to joining the faculty at Marquette, I was a staffer on the House Ways and Means Committee for the U.S. Congress.
That's how I met her.
Yep. I had that Medicare portfolio. And I did that for about 6 years. Before that, I worked for a trade association, the American Hospital Association. And before that, I worked for 5 years in the executive branch for the Centers for Medicare and Medicaid Services. So I've had a couple of different government positions.
And has quite a knowledge. So you that are listening, this is the reason why we wanted to talk about that, Lisa, is because you have an extensive background, whether it was working for the Centers for Medicare and Medicaid Services to where I met you for the first time was in your capacity in Ways and Means. And for those that do not know, many know, of course, I'm involved in the ambulance industry. And so you were instrumental in some stuff that we were talking through. Cost data collection and that construct came around with lots of conversations that the industry had with Lisa, and so, or Dr. Grabert now, as we would talk about it. But I wanted to spend just a little bit of time on that. Now, talk us through that. Now you're in academia, you're here at Marquette, and you've just most recently have gotten your doctorate. Mm-hmm. Talk a little bit about that and what that was about.
I was able to put together my own doctorate program, and I was passionate about working with a couple of different areas of discipline on our campus. So I have an interdisciplinary PhD with my main emphasis being in health economics, but also I pulled in from public health and nursing and also our political science department on campus because of my prior government experience. So I got to pull from lots of different areas from my courses that I took from my formal training. And then, of course, I did a dissertation, which was a lot of work, and I defended it in May and spent all of my dissertation on the Medicare program and evaluating different policies in Medicare.
And so we're going to get into a little bit of that because that's a part of some of the construct that I want to talk about today. I want to talk a little bit about Medicare, Medicare Advantage, payment reform policies. There's a lot of discussion happening right now in general in the healthcare world. The One Big Beautiful Bill has really propelled that even to more discussion, and I'm sure you've got a lot of opinions on that, and I'm going to ask you about what you can talk about and kind of opine a little bit about. But let's rewind before we set, because some people have a different vision of what a healthcare economist is, what you're doing. So talk us a little bit about that, if you can give a little clarity to someone who may not know much about what that is. They might have a viewpoint about it, but can you give us a little discussion around what it means to be a healthcare economist?
Yeah, for the most part, it's a drive towards doing research, and formal economics training looks for a causal relationship. So when you have two factors in place, does factor X cause factor Y? And that's primarily why I was interested in exploring economics, because of my background in policy. We want to evaluate policies that have been put into place and determine if they're actually meeting what was intended from the policy. And so if you can definitively say that a policy change caused a certain outcome, that lets us know if that was a good policy change, if we should go back and make some corrections to a policy, but it also helps us identify areas that may be more fruitful to target policy change versus others. So that to me is the core of what health economics is. It allows you to make a causal claim between a policy, which is what I wanted to focus on in my training, and whether or not the policy caused the outcome we aimed for as policymakers.
So let's talk through your dissertation and what you worked on there, and it was really Medicare focused at that time. So I know we talked a little bit about that and you shared some information, but I want to really share that with the audience. And if you're open to sharing that with, what was the dissertation about? What were you researching in the Medicare program that was a part of getting your PhD, if you can share that with the audience?
Yeah, so in the Medicare program, one of the most important decisions that a Medicare beneficiary can make is to decide to elect what's called traditional Medicare, or the program as it was envisioned in 1965, or they can elect what's called Medicare Advantage, which is when you select an insurance company to help manage your benefits. And there are different trade-offs that each beneficiary needs to consider when they choose either that more traditional route or the Medicare Advantage and insurance route. And in my dissertation, I compared between those two options. I studied how beneficiaries make those decisions. I studied if they make those comparisons, which is a big question in the Medicare program. And then when they do make those comparisons, is there a type of behavior that we might see when they're making that decision? So that's primarily what I studied. Then I also looked at a change for the Medicare program that occurred during the COVID-19 pandemic, where everybody's probably more familiar now with telehealth as a result of the pandemic than they were before. But the Medicare program largely did not cover or pay for telehealth services before the pandemic. And the U.S. Congress acted, put a policy in place to do that. And so I studied the effects of that new policy change during the pandemic and compared between both the traditional side of Medicare and Medicare Advantage.
And conclusively, what did you find?
So I found, specifically to the telehealth policy, the U.S. Congress invested roughly $5 billion in 2020 to increase fee-for-service or traditional Medicare services. They did not make that same investment on the Medicare Advantage side. So I went into the data assuming that we would see higher utilization and access to telehealth services on that more traditional side versus Medicare Advantage. And in fact, I did find that. So that's the direct causal effect of the policy change. But it was the interesting finding that I had when I looked at both those areas is that Medicare Advantage caught up to the fee-for-service very quickly. So after a period of just 3 to 4 months, Medicare Advantage beneficiaries had the exact same access to telehealth services as those traditional beneficiaries without that additional $5 billion investment, which was a really interesting finding. And then I had to sort of research.
What do you think caused that?
So part of, I think, the cause with that, and that's a lot of what I had to sort of research and understand, is that Medicare Advantage was set up as a private sector solution for managing and delivering health care. And so it's more nimble, and they're able to make changes without an act of Congress. But on traditional Medicare side, because that sort of investment and private infrastructure is not there, the U.S. Congress has to make an action to see any changes on that traditional side. So what was interesting is that on the fee-for-service side, you saw this investment that maybe the Medicare Advantage companies actually were able to take advantage of, no pun intended. So physicians and other professionals, when they built the infrastructure for telehealth, they may have been paid directly on the fee-for-service side and maybe didn't have a contract in place on the MA side, but they were giving those services to beneficiaries regardless of the type of Medicare coverage that they had. So Medicare Advantage plans may have been able to take care of the taxpayer investment in infrastructure and benefited from that without necessarily having to pay for some of that themselves. So that's one of the findings that we had. But also because those Medicare Advantage plans are nimble, they can make changes more quickly. They saw the value in those services during the pandemic, and so they increased access for those beneficiaries, which was not something that we expected to find. And so what I learned from that exercise overall is that we can make an investment on one side and maybe see a spillover effect to the other side of the Medicare program. But we also need to be careful about making sure that if it is something, an innovation in the Medicare program that insurance companies can benefit from, that we need to think about how to get them to also invest in those kinds of things and put policies and incentives in place to enable those things to happen.
So let's unpack some of that. And I know people are listening right now, and they're probably saying...
falling asleep.
No. I will tell you, the people that are going to be listening to this and say, well, wait a minute. We know why the insurance companies are getting into it. They've been getting these huge bonus payments, and we could see the data. And I know that was something that was really looked at under the Biden administration, saying, let's take that. And, and then... unfortunately, the provider community was very upset with some of the regulations that came out from the new administration, actually giving more of an increase to the Advantage programs. I do know that there is an intent to say, because it makes sense to me, we want to put more Medicare beneficiaries into the Medicare Advantage program. It gives budget surety to the government. I get it, understand it. It's just some of the points of your findings that says, well, wait a minute, we saw that they don't have the same restrictions in the Medicare Advantage world. So let's unpack that a little bit, because I do know that there is this angst amongst the provider community or the healthcare provider community relative to the managed care side of things. That is more restrictive. We have all this stuff coming out on prior authorizations. They're trying to look at that construct around it. Is there anything in the findings that you saw, or some things that you would say, in my crystal ball as Dr. Grabert, is there some things that we probably should be working towards solutions? Because it does look like that's coming. Anything that you can talk about that and unpack that just a little bit for us?
Yeah, so some of the stuff that I found and actually understood better in my dissertation is that when beneficiaries choose, and they're making an active decision with a lot of information at their disposal, there are clear preferences for either Medicare Advantage or fee-for-service Medicare. It's highly predictable that people who have a little bit of a higher income and who are duly eligible, so that means they have Medicare and Medicaid as a benefit, have a higher preference for traditional Medicare. And lower income, Black, Hispanic, less education, those are high predictors for people who choose Medicare Advantage. Now, some of the reasons around those predictors, I think, have to do with cost, but then some of it gets into access issues like prior authorization, as you just mentioned, or network adequacy. So from a cost perspective, a Medicare beneficiary who chooses MA is going to pay a lot less out of pocket on an annual basis, primarily than a beneficiary who chooses traditional Medicare. And that's because in traditional Medicare, a lot of beneficiaries purchase Medigap insurance. And it's an additional insurance product to give them certainty. That's is one of the things that they're probably looking for when they purchase that. And that's a pretty expensive product to add on to traditional Medicare. So there could be roughly a difference between $2,000 and $3,000 a year for a beneficiary in choosing MA versus fee-for-service. So it is much cheaper out of pocket because the premiums are cheaper. And that's part of how Medicare Advantage plans work to attract people to their product. It's a little bit of a cheaper alternative. It's cheaper in part because Medicare Advantage plans are paid from the federal government on a per member per month fee. And as part of that fee, they are expected to manage and give the beneficiary everything they need with maintaining cost control under that overall global budget. And because we expect Medicare Advantage plans to manage under that budget, We allow them to use utilization review tools like prior authorization and possibly putting together a more narrow network of providers that they have preferred relationships with. So the downside of Medicare Advantage for a beneficiary from an access perspective is you will have a restricted network in which you can get your services from. You can still get some coverage, but you'll be paying a higher price if you go outside of the network. But the other downside that you mentioned is prior authorization. So plans will use review tools and they'll have a set of services, and the provider who wants to order that on behalf of the beneficiary has to get permission or an authorization from the plan to make sure that the plan will approve it ahead of time. So when they bill the service, they will in fact be paid for it. And sometimes that blocks access to some things a beneficiary or the provider on behalf of the beneficiary thinks is necessary for their care. That's the downside of Medicare Advantage, and that's why we have those tools in place, because it aligns with the economic incentives. Now, on the fee-for-service side, there's open access. And so beneficiaries don't have any restrictions. There are very few restrictions. There's very little prior authorization. The administration's putting some experiments in place to change some of those rules a little bit. But prior to current policy changes, there are no restrictions, and beneficiaries in traditional Medicare can go see whoever they want. The con of that freedom is that they pay more out of pocket for it. And so beneficiaries have preferences. And so if you have more income coming in, you have more disposable, you want more freedom of choice, beneficiaries make the decision at a higher income level to choose that and pay for that. And so there's preferences that we can predict sort of where people might go depending on what they need. And cost is a big concern for a lot of Medicare beneficiaries, and they may be predisposed to picking Medicare Advantage for those reasons, because the average Medicare beneficiary lives off of just Social Security income, which is roughly below 150% of the federal poverty level. So they're making less than $36,000 a year in retirement, and so they're very income conscious. And they're very careful about how much money they pay out of pocket for things like their health care. And Medicare Advantage offers them a product that helps them budget better.
I want to unpack, I'm geeking out right now. I'm thinking, I'm trying not to cut you off, and I'm thinking I want her to talk through this process. But there's two components I want to unpack with you, that what you just said around Medicare Advantage. One is, and I did not realize this as much as I have been doing policy work, understanding the Medicare Advantage piece, because there is a quick increase in the amount of Medicare beneficiaries. I think we're over 50% now, 51% of people that have been electing it. And you made a statement that you said, Medicare Advantage is really targeted to the communities that are more poor. And that's what your studies showed a little bit of. Typically, if you had higher income brackets, you might stay in the Medicare fee-for-service model. I want the people that are listening to, and I know the EMS community, because a lot of people are talking about, why are you doing that? Because that's the second thing I'm going to unpack with you, is some of the coverage limitations around that. But it really gets down to economics. It gets down to what's best for their pocketbook. And so when you were looking at that, were you seeing it in certain communities in certain states? I know, for instance, in Michigan, it has a high propensity of people that have elected. It's huge in that area. Did something in your study bring an indicator around that outside of just what you said?
Yeah, so I did also control in my models for urban or rural residents. So there's a little bit of that, because you want to control for those kinds of things, because you want to make sure that's not sort of coloring what you're looking at when you are focusing on a specific outcome. So there's one thing that you said that I would say, I think there's a lack of consensus that MA plans they're targeting some of those populations. I think there's a lack of consensus among policymakers, academics, everyone who looks at the Medicare program. And I don't know if we truly know if it's targeting or if it's just patient preference that's driving it. So I think that's an open debate.
So the data is not backing that up. So conclusions that some people are making, you're saying the data is not conclusive on that. We don't know if it's patient preference or if there's been a specific targeting.
I would say that there's probably a healthy amount of data on both sides that support those things, and that's why I say there's a lack of consensus. Okay. Some of it may be the bias of the researcher as well. So as an economist, I have to say that. I mean, we all tried to not be biased, but we all bring our biases to the table. And I think in certain stakeholder groups, more of your government-based groups who have questioned the value and how much taxpayer dollars are going into Medicare Advantage, they would probably sit in the camp that's a little closer to it's the Medicare Advantage plans who are going after these populations, whereas other researchers who come in, I would maybe argue from a more neutral perspective about Medicare Advantage, have concluded, no, it's actually the patient preference and the patients who are driving that selection. Some government entities would go as far as to say it's favorable selection on behalf of companies, and they're actually insurance companies are going in and possibly cherry picking. I don't know that there's definitive evidence that supports that. Either way, you can predict pretty well, based on some of the characteristics of the beneficiary, which way they're most likely to go. And once we understand some of those factors, we can plan for it, we can budget for it, we can target and do different things around it. But we're finding more and more evidence that there are high predictive sort of variables that go with those. The other thing is Medicare Advantage plans have a higher penetration rate in urban areas than they do rural areas, which is a problem for access, for choice for people who live in rural areas. But for a variety of different reasons, a lot of plans don't operate and offer as much in rural areas. And you also have some geography that colors some of the populations as well, because you have some populations that have a tendency to live and reside in urban areas versus rural. So that drives availability of plan, drives some of the preferences as well.
So I want to unpack some things, because I think you're saying a lot of great stuff that just it resonates, number one, with me. I know it's going to resonate with people that are listening, because I like it that it's inconclusive if depending upon where the researcher's coming from. But ultimately, imagine the patient making a decision they want to go to the Medicare Advantage plan. I mean, sometimes it's hard for us to understand that because of our own biases as healthcare providers, that the patient actually elected a Medicare Advantage program because of the benefit that it offered them and the economics of it, depending upon the why I need that, which brings me into very an EMS specific question. This is something that has bothered me for many years, specifically over the last several years. And so there is a very strategic advocacy around this, because in the EMS space, if you call 911, Medicare Advantage plans theoretically can charge you whatever out-of-pocket they want to, and they're doing that. And there's not a restriction on that like there is in other services. We're not technically, I guess, under that definition, like emergency medical services, the out-of-pocket for a Medicare Advantage beneficiary can't be anything more or greater than what it would have been if they had been a fee-for-service for certain procedures and things. Unfortunately, there has been a loophole in the definition of that change to where theoretically, if you call 911 and you're having a heart attack and you have a Medicare Advantage plan, they could subject you to a $350 copay. Whereas if you had Medicare Part B, it might be 20% of a ride that might be $80. And so there's been a big discussion around that, because we have some plans that are charging them $400, $450, but the Medicare Advantage recipient, when they're looking at that, they're like, oh, great, I have no out-of-pocket for my primary care physicians, I get vision, I get hearing, I get things that normally the Part B doesn't. What are the limitations on that around the Part C? Did you do anything around like coverage issues? They offered different things. You alluded to this in COVID-19, where there were certain services, like it was pretty quick how quick they caught up within 4 months, and that's because they have this flexibility. Is there some restrictions that should be put more in place? I get the flexibility. It allows for innovation. It allows for adapting. You don't have to wait on Congress to codify something to make something happen like in the Part B program. But is there some nuances around that could be more directional at the government level, in your opinion?
Yeah, so it sounds like some of what you're describing fits into sort of network adequacy and how Medicare Advantage plans put those networks together. So it sounds like in some of the examples that you gave, very often someone will be picked up by an ambulance. So they can't they don't have choice in that, in an emergency situation. So they have no choice. Whatever ambulance is there is the ambulance that picks them up. But on the back end, if that ambulance happens to not be part of that network that the Medicare Advantage has in place, they may be on the hook for paying a lot more out of pocket if they had otherwise been a fee-for-service beneficiary.
Correct.
So, I mean, part of what, from a policy perspective, what you can change is for some of those services, they should be included under the network adequacy requirements. So that's a policy area where people can go after. Seems like that could be a change that could be done without the U.S. Congress, and maybe something that could be done within the executive branch itself.
I agree.
Yeah, just kind of off the hook, kind of sounds like that. And I think possibly what would empower the executive branch to be motivated to change those network adequacy policies is data that shows this service consistently is costing these beneficiaries this much out of pocket, and beneficiaries probably have preferred into this route based on income. And these are examples where that sort of breaks down. So we're not really respecting all of their preferences in choosing this option because, and many people would disagree with me, but I argue beneficiaries aren't aware of all these trade-offs they're making when they make these choices. They don't, I'm not sure they fully understand what the implications of a narrow network are. They may be thinking of sort of routine care. My doctor's in the network. I go see my doctor, but they're not thinking of that situation where there is an emergency, where they don't have choice, and how protected they may or may not be in those situations. And I do think that the Medicare program can do more to provide education to beneficiaries so they make even more informed choices and have more information at their disposal today. So one of the things I've written papers on is what kind of information do we have to highlight for beneficiaries when they are in open enrollment and they're able to make a change every October 1st through the end of the year when they look at Medicare Advantage and fee-for-service. There are lots of ways beneficiaries make those decisions. Some of them call 1-800-Medicare. Some of them have a broker on speed dial, so they're using a broker to help them navigate that. Some go online and use the Medicare Compare tool, and that's where I've argued there should be some changes in what we show people because I think the highest percentage of people are using that. But some use the handbook they get in the mail. So people use lots of different sources to try to predict and figure those things out. But if you go online and you compare, if you and I went right now and compared between fee-for-service and traditional Medicare, there's not a lot of information on network adequacy or prior authorization when you look at Medicare Advantage. There's either a red X for Medicare Advantage because it's a downside of the benefit. In fee-for-service, there's a green marker because that's not an issue in fee-for-service typically, but that's it. That's all we're really telling people. And we could tell people a lot more. People should be able to seek out more information and get that information if they want to. But we don't have the capacity to sort of let them know and give them more color into what's included and what's not in a network. And if they had a better understanding of EMS services and Medicare Advantage, it might be something that a small percentage of people actually do want to see. They don't have access to that information today. But if they had access to it, maybe they would make a different decision.
And I think what's important, too, that I know people are, and I know from my standpoint, I mean, I've been in healthcare for almost 30 years now. And my parents are getting older. My dad's 80, my mom's in her 70s. They're looking at these plans. And as I'm working through it, I know, like going through, I'm like, okay, we have to do this. We have to help them understand this. What are the current ailments? Like, my dad has certain conditions. And so what would be better for him? Mm-hmm. And then what is that cost going to be? But I'm having to navigate. So you've got this generation trying to help our parents. And some people that have the acumen like I do, I think I'm pretty much know the healthcare landscape from the finance perspective. And if I'm trying to get that information, what about those that don't know much about it and they're trying to call an advocate or they're looking at a website? So I think you make a really good point that says we could probably do better. Yeah. We could do better from being a little more transparent. And I'm hoping with the new administration coming in, looking at the way that our systems are set up, the technology side of it, can AI help us in some of this and help? I believe it could. And it could help educate and inform consumers more. This is the last question I'm going to ask you, and then we're going to pivot, and I want to talk a little bit about some stuff in the one big beautiful bill and what your perspective on that is. But I know that there's some stuff that you're working around Medicare Advantage, and I know this administration's very, very interested in continuing to move more people into the MA space. And so what do we need to do? What do we need to do? There's a lot of talk right now that the health plans are abusing the MA space. They're profiting off the back of patients. That's the provider's argument. And vice versa on the health plan side of it, it's they need more money because there's a sicker patient population, more chronic conditions that they're having to manage through. This is paid on a per member per month. They should be bonused on the outcomes or whatever. What are some of the things in Lisa's crystal ball that you would say, you know what, after all the research that I've done in this space, here's one or two things that I think out of the gate that needs to be a part of this program if we're going to move more and more people into the managed care?
Yeah, and I think it's the financing that goes, that puts more of a spotlight on Medicare Advantage, but it's also the growth and that more beneficiaries are using their feet and choosing Medicare Advantage. And so I think it's the right time to be focusing a little bit more on that part of the program versus traditional Medicare. So I think for the long term, we need to make Medicare Advantage more competitive amongst plans. We don't have a lot of competition right now amongst individual plans. And I've written some pieces on envisioning a new competitive bidding program for the Medicare Advantage. So the way that I would envision it, it would be at the county level, which is where people make their local healthcare decisions. They're choosing a healthcare option at the county level. And I would make traditional Medicare a part of that bidding system. So you can imagine almost traditional Medicare as its own plan. So it's still an option for beneficiaries. They can choose that, but it has to be competitive with the rest of Medicare Advantage plans at the county level. And in some cases, the Medicare Advantage plans will be more or less competitive with fee-for-service. So it's important to keep that choice option for people that want to elect that. But if we start to get more competitive with the bids and where we set the benchmarks at the county level, we can actually bring up all of the Medicare Advantage plans. They should start to compete against each other a little bit more. In the system we have today, there's not much competition. And it's something that needs to happen in the long run in a transition to get there. And there's a lot of pieces that need to be put in place. Like, for example, if we do have Medicare Advantage and fee-for-service or traditional Medicare competing, we have to measure them in the same way. And the quality measures that we use are vastly different between those. And on the traditional side, we measure providers. We measure hospitals, nursing homes, home health, physicians. We measure them all differently. In Medicare Advantage, we're using more plan-level measures. Are there a lot of beneficiary appeals? So there are things that focus more on the patient, but actually at a higher level. And if we want to establish a truly competitive system between the two parts of the Medicare program, we have to measure them in the same way. And that should be a component of the system as well.
And you did some published work on this, you said?
Yes.
Was it published in?
It was published in the Journal of the American Medical Association with my colleagues Dr. Brian Miller and Eric Hargan. The three of us authored a competitive bidding piece together.
And this was published when? I'm going to actually, for our listeners that are talking about it, I'd love to get that out there.
I think it was 2023.
So 2023, you, Dr. Miller, and Eric Hargan, who was the former Deputy Secretary of Health and Human Services under Trump 45, y'all author that together as well. Perfect.
That's kind of our vision for longer term changes, but as I've heard Eric say many times, and I really respect it, it does envision a process of radical incrementalism. So it's smaller steps over time that lead to a competitive bidding change in the Medicare program is a very large change. It's not something that we would envision happening a year from now. But there are a lot of incremental steps that can be put in place to ready us for a system like that.
Okay, so those that are listening, we're going to stop the Medicare Advantage conversation. We're going to make sure that go read this article. I'm going to go back and read it. I know you've told me that you guys have done that. Eric's told me that we've done paper together. I want to go back and read that because I think that's instrumental as we continue to keep working towards this long-term. Medicare beneficiaries are choosing. Whether it's a targeted approach, however you want, they are choosing to go on Medicare Advantage, and that is not there's not any monumental change. I think I read something from Kaiser Family Fed that actually did a study over the last 10 years of the inception of it, but I think even when they implemented this, it increased faster than they even anticipated. I think it was like they said 76%. Even CBO scored it incorrectly in the very beginning, that the adoption of it was much quicker. They had no idea that the people would elect that much. So it's a problem. We have to discuss it as a healthcare community. You can demonize the payers all day long if you want to, and the payers can demonize the providers all day long, and we can keep putting all these implications in there, but we have to move that. I'm going to switch the subject. I want to talk about the One Big Beautiful Bill and some of the changes that have happened. I know people are reacting to it in different ways. And so as a healthcare economist, and I know you've focused on the Medicare side, but you've got a long history in payment policy, working either with CMS, working for Ways and Means, and now. But talk me through, and really about the healthcare provisions in Medicaid. I've heard just a lot. Some of it is just, it's fear-mongering. There's a lot of discussion that's happening, but you can get so much misinformation out there right now. But let's level set. We talked a little bit about this as well, and the Medicaid, and how I've seen the numbers, and the 10-year score with CBO, of course, which 76% of the savings aren't going to be realized until 2030 or greater. We know what really happens once things start taking a long time to implement. We know politics gets involved. It's kind of delays. It's like, yes, I call it funny money. It's like funny money scoring. But let's talk about that initially with this managed care and Medicaid, and what the implication, what providers really should be looking at from your mind, understanding policy.
Yeah, so I guess I'll take on the fear-mongering first, because it's one of the things that's more or less baffled me as a health economist. So if I could pick one stakeholder who's maybe been contributing most to the fear-mongering, I'll take on the hospitals. So I think the hospitals have done a tremendous amount of fear-mongering around the new changes to Medicaid in the bill. And it's kind of typical of how hospitals behave when you threaten to address any inefficiency whatsoever. So it's typical of how they behave. And I guess the best example I can give you is, one of my friends was asking me, well, tell me your perspective. Like, what do you think about this? And I said, I'm just trying to figure out how hospitals are going to take a huge financial hit and hospitals all over America are going to close. Because I can't do the math. As an economist, I cannot come up with the math equation that goes along with that rhetoric. And so the example that I use is, so I know the Medicare program pretty well. On an annual basis, about 20% of Medicare beneficiaries have a hospitalization. That's it. And so the first reaction my friend had was, really? I would have thought it's a lot higher. Yes, we're talking about your sickest population in the healthcare system. Only 20% of them have an actual inpatient hospitalization stay in any given year. So most people don't. So then if you kind of figure, I understand that number from Medicare, what's the Medicaid number? Well, it's got to be less. And so I went on my phone and I asked ChatGPT real fast. And sure enough, 14 to 16% of Medicaid beneficiaries have an annual hospitalization. Okay, so you do that math. You might be losing some of those patients because they may lose Medicaid. But then let's look at where the Medicaid changes were actually made. Primarily, if you look at work requirements, that was put on the population that is able-bodied. So that is a small portion of Medicaid. If you look at, and when I asked ChatGPT the question of how many able-bodied Medicaid recipients have a hospitalization, it couldn't give me that number. It doesn't surprise me because I don't think that's a highly studied population. It's the newest Medicaid population, but I'm willing to bet that's even less than 14%. So that's the population that may lose Medicaid, that then would cause a hospital to lose revenue because there is no inpatient stay. That may happen in less than 10% of a very small population. That's where the loss of revenue is. So I don't see how that potential loss of revenue from a hospital manifests in hospitals closing all over the United States. It's just not possible. It's just fear-mongering.
And I'm going to concur with you. The math, like they say, the math just doesn't math. when you start really looking through the process. And even when you get down to the able-bodied, there's a lot of exclusions in that. So there's an exclusion if you have children under the age of 14, so there's all of this as you start peeling that onion back, and it's like, okay, guys, are we really looking? Let's put the math together. We're making the assumptions that every single one of these people that are on Medicaid are actually utilizing the services of Medicaid. Sometimes they're not.
Yep.
I heard, this was very interesting. So I heard from one of my colleagues that works for that. They were talking, they're like, we're getting lots of stories that people are like, there's these companies out there that are qualifying people and finding different avenues to get them based upon the bounds of the current law before the new laws take over in place. And they're like, this is the concerning to us. We didn't realize this was going on. I said, you didn't. Several of us already knew this. I mean, I was talking about one thing around people that were on dual eligibles with Medicaid. Oh, don't shoot me, guys, if you're talking, but we all know it's going on. Probably shouldn't. But I'm going to say it anyway. It's many times they might have, and their family owns, 100 acres of land, and it's a net worth value of a few $1 million, but yet they're putting it and scrolling it away into different trusts so they can put them on Medicaid. These little things are happening, and that was kind of addressed. And so I think that we have to wake up if we're looking at the cost of care, and wherever you stand on either end, you might be more, because I'm all about helping those that need help. That's my own personal mantra. I'm not about, if you need help, we are going to help you. And we should, as Americans and humanity. Other people feel differently. That's just where I stand on this piece of it. And I think Medicaid's a piece of that. Like, this is for our most vulnerable population that need it. But if you're exploiting the rules and you really aren't one of the vulnerable, but you're trying to protect your assets, I think that's wrong. And I do think we need to have, and I don't think the federal taxpayers should be paying for that. And that's my perspective of it. So Medicaid, I think there's a lot of that in there. I think there was, I think Arkansas was a state that actually did workforce requirements. And I think when the numbers came down to it, it was very nominal, the individuals that came off. So I think you're right that there's going to be some, and then some people that were on the rolls probably shouldn't have been on. And I think that's what they're beginning to see, and some of those numbers to come out of it. So I'm going to switch stuff. Able-bodied, fear. I think the math doesn't math. As a healthcare economist, you're saying, I just don't see how hospitals are going to go out of business. I will tell you, in the EMS industry, there's always been the concern, especially when you're a safety net, is for some of these people, we do know there's going to be some loss of cover. People that may not have should have been on there to begin with, they were a payer source regardless of where you stand on it. But ultimately, when you don't have access, what do? You wait, and then ultimately you call 911. And so we do know that we then have to go pick the patients up. And so what is your thought process around, I think they did this, there was some concern about the rural access, but that's why they started that rural stabilization fund. I'm a big advocate for maybe we should be thinking like of an EMS stabilization fund or something. I'm just throwing out EMS because I'm EMS. But is there some other factors that need to be considered as we continue to move down this road of being better fiduciaries?
Yeah. So I think the U.S. Congress, and one of the highlights that people might not know about in the One Big Beautiful Bill is the fact that they have started a rural sort of stabilization program. So when you make big changes to a program, you don't always know what is going to come out in the back end. So if you can put a few things in to plan for unintended consequences, that may be how we use this rural stabilization fund. So I'm really excited about this because it's access to a lot of new capital, and the executive branch has a lot of power in how they can allocate those resources, which is a nice change compared to how Congress has sort of worked with rural areas in the past. It typically follows a statutory formula. The executive branch doesn't have a lot of flexibility. And so we end up seeing resources that are meant to help in rural areas get sucked up by large urban areas anyway. So we don't have that problem with this particular situation because a lot of authority was delegated to the executive branch. So now the challenge is for the executive branch to make good judicial decisions when they are putting that money out the door. So there are a lot of targets for that rural stabilization fund, but I have a few recommendations on how I would use it, and I would advise some of my colleagues and friends when they consider how to get out the resources of this new $50 billion stabilization fund, which is quite a bit of money. So the first thing that I would look at is I would prioritize states who have not expanded Medicaid. Wisconsin happens to be one of those states, and I'm from Wisconsin, but that's a state where we've already had possibly some access issues with Medicaid. And the point of the fund is to address access issues with Medicaid. So the first set of applications I would give priority to are the 10 states in America that still haven't expanded Medicaid. That seems like a good place to target the majority of the resources, I would say. Because all the Medicaid recipients in those other 40 states have benefited from 90% match rate from the feds on the able-bodied population in a way those 10 states haven't since 2014.
That's a good point.
So I would say if you're going to prioritize, let's try to get it in those 10 states first. The next place I would say we should prioritize is anywhere other than a hospital. Because there are hospital programs and rural support.
Oof, you just made all the hospitals listen to that.
I'm sure I did. But there are rural support programs for hospitals all over the statute. There are sole community hospitals. There are critical access hospitals. There are rural referral centers. There are millions of categories, not really millions, but it seems like millions of categories that already get special differential treatment from taxpayer dollars in rural America. We've tried that experiment. Still, we have access issues and problems in rural America. I would say, as a health economist, it hasn't worked. So let's try something different. Let's prioritize that money for other types of providers who may be able to really make a difference in rural America. I'm talking about federally qualified health centers, community mental health centers, EMS. These are the stakeholders that I would prioritize giving these resources to because I think they can better serve the needs than a brick and mortar rural hospital that is just an affiliate of a branded hospital in an urban area that may have just purchased a rural hospital because they looked at it as a pure revenue center. When I drive through rural America, which I do very often, especially during hunting season, I see lots of critical access hospitals in the state of Wisconsin, up I-94, that used to be independent standalone facilities that have now been purchased by brand hospitals, places like Mayo Clinic, who have purchased to get a further reach into rural areas for the purpose of revenue, not for the purpose of being there for a patient. And so I've observed corporatization of hospital behavior in rural America. So I would suggest let's stop investing in that model. Let's try a different model for investing this new money in.
And people now know why I've asked Lisa to come on here, and her becoming a healthcare economist now has brought a different value that you're seeing things through. And I appreciate your passion. Your passion comes out, and you see it in the model of what you've been working at. And you made a statement here, let's do something different. We've been doing this since 2013, 2014, and probably a lot.
Yeah, we've had special hospital designation since the 1980s when we moved off of cost-based reporting and we created all these subcategories just for hospitals. We don't have subcategories for physicians. We don't have subcategories of nursing homes or home health. We only have it for hospitals. So we've tried for 45 years some of these experiments, and they haven't worked.
And so I think what I'm hearing you say as well is I'm an advocate for trying something different. And let's use this rural stabilization fund as a way to say, let's prioritize this. Let's not give it to the hospitals this time. Don't get mad at me. I have a lot of great hospital friends. They're wonderful people. But we've got to do something different. You know, what do they say is the definition of insanity? Keep doing the same thing over and over, expecting a different results. And so we've got to change that. And that's what I'm hearing you say so passionately. As we wind this down, I wish I could sit here and talk to you forever, but I would like Lisa in her crystal ball, if you had one or two things that you would love to see in the next 12 months in healthcare change, and it was in your crystal ball, and I know you have a good crystal ball because you have a lot of experience doing this. What would those two things be?
I think maybe it's just a bit more education of the public on where resources are and where they are not. So I do highlight hospitals pretty often, but that's because the sheer amount of federal capital that goes into hospitals is astonishing compared to the amount of capital that goes into any other actor in the healthcare space. The reason we don't see competition in healthcare is because there's massive consolidation, and that consolidation happens because of access to capital. You can buy out your competitors and dominate a market if you have access to capital. And I would argue across several different types of programs, that's what hospitals have done. They have access to capital from the 340B program. They have access to capital from purchasing physician offices, flipping them, and a differential that they get on payments from the Medicare program. They have medical education resources that they get that no other providers get. It's astonishing the amount of sheer capital that goes into one part of our healthcare system, which is also the part of our healthcare system that we hope people have the least amount of interaction with. When we have situations where people end up in hospitals, that's not the best outcome of our healthcare system. We want to try to avoid a hospitalization. If that's what we want, why are we putting all the dollars there? We should not be surprised that everything in our healthcare system is dominated by hospitals, because that's literally where we're sending all of our money. And to the extent that the public is more aware of that, I think we can help change the system. People don't understand how much of their individual tax dollars go to support just one part of our healthcare system.
So you think, so if in your crystal ball, you think more public information on getting information out to the consumer to understand where the dollars are going.
Yep.
I know hospitals are massive employers in a lot of their communities as well. In some of their communities, they are the largest employer. So they're employing people. So you get into this dynamic around not just being healthcare, but it's also a revenue generator. It's employing individuals who are putting back into their communities. So I know that there's a big issue. It's a complexity, but simple education. And I think the transparency side of things, I remember talking to Eric about that was one of their initiatives, even under the Trump 45 administration, was more transparency in healthcare, payer transparency, hospitals being transparent, moving that to all of the other services. Like, so consumers know, what am I paying for? It's like the only area that you don't really know how much the cost is going to be to have something done or what have you. So what would be your second thing?
My second thing, I mean, I think it's just giving, it's on the lines of transparency, but it's empowering the patient more. So when they make decisions, when we talk about traditional Medicare and Medicare Advantage, I think they need more information. Not all of my colleagues agree with me, but when you're faced with a county that has an option of 43 plans, is it hard to pick from 43 plans?
It's a lot of options.
It's a lot of options. As an employee of Marquette University, I have 2 plans to choose from. That is it. That is how my employer has decided to manage and put everything together. But when you look at my choice and my ability to make decisions around those choices as a consumer, 2 versus 43, maybe 2 is not right, maybe 43 is not right, maybe it's a happy medium in the middle, but I don't know that we're necessarily giving people as much information as they need to make a truly informed choice that will benefit them for the healthcare needs that they have individually. And so if we can give them more information, because we have the information, we're just not building the tools to empower people to use it. And so we need to make a few, and I think that's going to change with this administration. There's a lot of good, positive rhetoric. There's a lot of partnering with technology companies. It's all available, but sometimes the government's just a little clunky and a little slow and a little behind. But if you can figure out how to sort of cut through and actually partner people together with the government, we can give people a lot more information and they can make better decisions.
Well, I'm going to leave it right there. Wow, what an informative conversation we just had. There's a lot of information to unpack here. And so I want to say thank you for staying and engaging. And Dr. Grabert, thank you so much for joining us here on the Leadership Lab as well.